I see that Megan is here. Megan, if you'd like to get started a few minutes early, we can go ahead and do that. Okay, wonderful. Kemi, if you can advance to the next slide. I see Megan's here and we can get started.
Oh, goodness. Thank you. Wait, I'm still muted. Good afternoon, good morning for some. My name is Megan Dunham. I am a social worker and program manager down in New Orleans, Louisiana at the Institute of Women and Ethnic Studies. I'm very honored to be here. I attended all of the sessions this morning, and I'm so grateful that we can spend this time in this session tying it all together. So a lot of the things that you learned today in the clinical and non-clinical workshops will be binded together and neatly packaged within this presentation about trauma-informed care. A little bit more about me. I have a background in public health, and I love public health research, data, and also primary care facilities and practices as well. And then I use that knowledge to go in and get my master's in social work, where I became a social worker. So I combine both of those disciplines together to talk about what I'm talking about today, which is trauma-informed care. And that is something that is deeply personal for me and has driven all the aspects of my career thus far. So it's very important to me for me to be here to talk about this work and also to combine all of the things that we talked about this morning. So let's get started. So this is my slide. It's a little different than the last one, but we can advance here. I don't have any financial disclosures or any conflict of interest when I present this material. It's just something that I'm deeply moved by. And like I said before, it has been an important role in my work thus far. Our learning objectives for today, of course, in order to get to talk about trauma-informed care, we have to take a deep dive into what trauma is and the impact of trauma on individuals, families, and communities. We're going to talk about the different signs and symptoms of trauma and how they can look in various healthcare settings as well as in the community. And then we're going to identify strategies for safe and supportive environments. That's that trauma-informed care piece. And then we're going to take some concepts from some earlier workshops, such as applying empathetic communication and best practices. And then we're going to utilize trauma-informed care plans and how to integrate those things within our EHR systems and with our daily practices. Now, all of those things considered, please know, again, the first point is defining trauma. We're going to be talking about trauma today, and I encourage you all to take care of yourselves throughout this presentation. There's some topics may be difficult to listen to. I encourage you to get up, stretch, cross your legs, grab a blanket, do whatever you need to do to sustain yourself during this time. If you have any questions, please put them in the chat and the team will read them out for me so I can address those. So now we're going to dive in with a pretty startling statistic that really can ground us into our work that we've done all morning and then to continue even after this series is done. Trauma-informed care practices are super important. And we also know that our roles or your roles in primary care are very important. But just to bring that home, we see that nearly 30% of individuals that had a healthcare visit and within 7 days before a completed suicide. So that lets us know that primary care is super important to prevent diseases, but also to prevent mental health challenges that may lead to a completed suicide. And that is a very tough statistic to hear. And I just want to ask you all in a quick poll, how does that make you feel? Are you surprised to hear that statistics? Does that surprise you? Is that something that you've heard before? Oh, I see two. Okay. Not surprised, but also surprised, not surprised. Oh, yes, our system unfortunately does not treat mental health at the same level of importance as physical ailments. Yes, yes. We'll get into that. Thank you, Chase. I have not heard the percentage, but I'm not surprised. See a lot of yes, I'm surprised, very surprising. Yes, I even see a very sad face. Right. We do depression screenings. We're going to get into some of those screenings that can help to alleviate this. So thank you all for participating. And I see the poll now, if you all can transfer your thoughts to the poll. Okay, thank you all for participating. And that is a statistic that surprises me. Even though I present on this multiple times, this statistic is always just a little uncomfortable to talk about because, as I see in the chat, providers need more education and also expanding what is a provider, right? We're all providers working in the primary care scene, even from the front door all the way to the back end of the clinic, all the way to those who work in medical billing and coding and all that. So we're all providers. So how can we all get on board to realize that we all have a price to pay when it comes to trauma-informed care? I'm gonna go to the next slide. Okay, now we're gonna dive into what is trauma. I have four, oops, I see. Okay, I saw the poll results. Thank you all for participating again. These are some definitions, common definitions of trauma. The two on the top are very clinical. One is from SAMHSA and one is from APA. The other two on the bottom are from the National Council of Mental Wellbeing that are meant to be more accessible for people who are not necessarily clinical. For this presentation, I'm going to refer to all four, but we're going to start off with the most common definition of trauma from SAMHSA. And that is trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as a physical or emotionally harmful or threatening, and that lasts a long time and adverse effects on individuals' functioning and physical, social, emotional, or spiritual well-being. That is a huge definition, right? What I like to do is go down to the definition that was created for teens, because we know that in the primary care health system, we don't always see adults. And so this definition says trauma is going through or seeing a deeply distressing event that can feel overwhelming. That definition is a little bit more digestible, right? And so from that, we can continue to go on to see examples of trauma. Examples of trauma could include abuse, neglect, community violence, disasters, pandemics, and even epidemics, war, grief, and a very common thing that causes trauma is a shift in life expectations or life experiences. And so from this list, these are all common things that we probably have heard about working in primary care within the last month. Right. So that brings things home that not only are our clients and our patients experiencing some traumatic events in their life, we may also be experiencing those as providers in this field. So in a little later, in a few slides, we'll talk about how to sustain ourselves as professionals as well. Is there anything from this slide that you find surprising or did not consider as an example of trauma? Feel free to unmute or put it in the chat. Okay. The pandemic. Ah, yes. Thank you, Leticia. That's something that caught us all by surprise. And some of us, many of our communities are still coping with that shift in life. I think, thank you. And so we just talked about some common indicators of trauma, but now we're really going to dive in to see how common is trauma. According to SAMHSA, again, approximately 61 of individuals in the United States have experienced at least one traumatic event in their lifetime. And then to take it back a little further, about 64 adults in the United States report that they've had at least one traumatic adverse experience before the age of 18. Again, we're realizing that primary care is not just adults. We really need to be trauma-informed for our littles as well, our youth. And then this is particularly, it shows up a lot more in our vulnerable populations. In a few other workshops that I attended this morning, all of them mentioned vulnerable populations. And that is something that is exacerbated by social determinants of health and our traumatic instances that may lead into healthcare and even prevention of healthcare. Trauma can be different types of trauma. Acute trauma means that it happens from one specific event. Chronic trauma, of course, means over time. Complex trauma may mean a mixture of both acute and chronic. It could be multiple instances of trauma that happen over time, and the results are also over time. Vicarious and secondary trauma is something that we may experience doing this work. It contributes to compassion fatigue because we are constantly hearing some traumatic instances, and we may feel those experiences as if they're our own. And over time, we may become numb to those things. And those are two outcomes that we try to avoid along with burnout. And the last type of trauma that we should be assessing for is adverse childhood experiences. And this is a 10 instrument with 10 questions that assess for trauma that happens before the age of 18. And it's because of that data that we get that second point here about the 64% of adults. And one more thing I think is very important to mention, that you may be familiar with a diagnosis that is referred to as post-traumatic stress disorder, or PTSD. PTSD and a trauma experience are not the same. There are a number of reasons why someone would experience a trauma event and not develop PTSD. And earlier in another workshop, we learned about protective factors. And so protective factors and things that protect individuals from having extreme mental challenges are what prevent people from having a traumatic experience and then it not shifting into PTSD. PTSD is a mental health diagnosis that requires several criteria to be met before it can be labeled as PTSD. So it's very important that we do not combine one traumatic event as to equal post-traumatic stress disorder. We don't want to do that with our populations. We don't want to do that within ourselves, and we definitely don't want that to be the stigma of our workforce. Now, one of the reasons, again, the protective factors play a piece is because people who have protective factors may have community that they can lean on. They may feel comfortable in their healthcare provider facility, and that's what we're working on today with trauma-informed care. And then they also may have other protective factors, such as environmental factors where they feel safe where they live. They can take a walk, they can do mindfulness and wellness activities in their neighborhood or within their communities without fear. Have you ever heard of protective factors? I know we heard of them earlier today, but before today, have you all been implementing those in your work? I'm sure you all have. I truly believe that you all are ahead of the game. I know that that most of you who are in primary care settings are collecting HEDIS data and are doing well on your UDS data. So these things are in your system somewhere, I can assume. It's just informing everyone about those things, and not just our clinical staff and not just our admin or finance staff. Thank you. Thank you. Now I have another poll here. What are some ways that trauma can impact one's overall health? Mentally, physically, behaviorally, or all of the above? Yeah, I see some all of the aboves in the chat. D. Oh, wow, 100% all of the above. This is great. This is absolutely great. So when we go to this next slide, I definitely want to hear from you. What are some ways that trauma can affect our physical health? Either come off of mute or put it in the chat. Blood pressure, weight gain, aches, weight loss, headaches. Yes, that's a very common one. Chronic pain, injuries, hair loss. Yes. Nutrition, diet, weight, panic attacks, social relationships. Social relationships, yes, that may come into another block here. Chest pain, decreased immunity to leading to chronic diseases. Yes. Sleep disturbances, lack of sleep. Not wanting to do anything after work. You just go home and do nothing. Yes. Signs of burnout there. Okay. Eating, too much sleep. Yes, that's another sign that we'll get into when we start talking about those screeners. Okay. What about mental health? How does trauma impact our mental health? How can that look? Ooh, so many in the chat. This is great. Anxiousness, angry all the time, not wanting to interact. Right. SI, suicidal ideation, depression, sleep terrors. Brain fog, sadness, depression can lead to suicide. They stay lost, they're not focused, difficulty focusing, insomnia. We see that again, frozen thought process, isolation. Yes, and we know isolation can prevent people from socializing with their friends or even coming into the clinic to get the care that they so deeply deserve. Irritability, memory loss. Yes. angry, aggressive. Absolutely. You all are on it. Now, how do those things affect our behavioral health? Striking at others with their words, yes. Risky behaviors, angry, has a social impact, yes. Getting into arguments, loss of patience. I also want to go back to social impact because it may be that someone is retreating into isolation, but it also may mean that they're just too social and not focusing on other things that maybe needs in their lives. It affects the ability to cope, unavailability to family and friends, mania, yes, backlash, aggression, anxiety, separation anxiety. Oh, job loss is something as well. Yes, thank you all. Loss of functionality, absolutely. Absolutely. So you all fully understand the scope of how trauma impacts overall health. And so now we are going to use what we have that you already know so much about and transform that into what do we do with that? How do we transform that into having a trauma-informed clinic, trauma-informed workforce, trauma-informed teams and staffs, right? Because you all already know how this looks, whether it's for you or the client or the patient, but how do we transform that into something that can have sustainable impact to make our clinics trauma informed? And so now we use everything that we just talked about. I'm so happy that you all put it in the chat so you all can scroll up and scroll down so we don't lose those data points. We have the 6 guiding principles of trauma-informed care. That was a collaborative effort created from CDC and SAMHSA. So you see the public health and the mental health really have to get together to really tackle this issue to make sure that we have trauma-informed practices that are adaptable and sustainable. So first, we talk about safety. Safety, we need to have a clinic that is safe, but also physically safe, but environmentally safe, as well as knowing that our care teams are trustworthy and that they understand where we come from. They have great understanding of our cultural components, and they are here to help us and understand where we are coming from. And so that's what I think you all already do so well because you have been here for hours, right? So congratulations on that. You've been here for hours. I think that, that shows commitment to safety and also commitment to learning. Trustworthiness and transparency is very important. Allowing team members and community members to collaborate on the same team. If you have any opportunities for community members to come in and take part on any advisory councils, I know for most primary care organizations, you have options for your quality improvement team to actually bring someone from the community or a few people from the community to sit on the board and to actually talk about some of the things that could bring better quality to the health center. That's another way to involve people in the community and also those with lived experience that may not translate directly into science or education that will require a degree. Those things are still very important because those are the people that you are serving, and it also reflects the staff that makes up the primary care system as well. Peer support is extremely important, and that is peer support within the clinic. Peer support within the clinic is super important because it's important for you all to be able to provide trauma-informed care, but also know that there's support there to prevent that vicarious trauma that we talked about earlier, to prevent burnout, and to also share ideas with one another to make the clinic to make the functionality of the clinic more acceptable for a working environment and for our patients that we serve. Collaboration is important as well, and that's also collaboration between teams, the interdisciplinary teams as well. Remember earlier I talked about talking to your finance team, talking to your quality team, the behavioral health and social work team should be talking to the physicians, and all of those, and a representative from all of those should be talking to patient care experience, should also be talking to those who are actually being served. Empowerment, voice, and choice is something that should be on the employee level as well as on the patient serve level to make sure that voices are heard and that things are rectified in a matter that gives dignity to both employees, the health center, and to the client. And then also recognizing cultural and gender challenges, and that may be that may require looking at what is currently happening here in the present, but also taking time to go back in time to learn the history and learn some of the injustices that have been present for a long time that contributes to those social determinants of health, that also contribute to health equity, and how we can change those things by combining, again, all of the things that you learned about this morning to create trauma-informed care. I know there's 6 guiding principles, and that is a lot, but I would like to encourage you now to know that you have been doing this work. They may have been in pieces and bits and pieces and all over the health center. Some things may be written down in manuals that we never go to, but these things, putting those together, these things are really what make a trauma-informed care environment. And also realize that one size does not fit all. So one health center is not going to look like the next, depending on the population served and the workforce that is employed there. Earlier, we learned that we need to prioritize our actions and then make a path and lead others to that path. We learned about that during the keynote. We also learned that social determinants of health encourage us to make safer environments, but they also push us to go past our insecurities. And they also push us to go in and forces us to learn past our insecurities. So all of these things together make a trauma-informed care practice. Is there anything on this slide that you haven't particularly heard before when talking about trauma-informed care? Whether it's safety, trustworthiness, peer support, collaboration, empowerment, or addressing historical factors? Do all these things sound generally what you would think of when you think about trauma-informed care? And keep in mind, if something doesn't look familiar, it's okay to say that, and we can spend some time in the Q&A discussing that. So feel free to say that as well. This is a learning environment, even though you all are the experts, as I have seen in the chat before. So now we're going to jump into some practical ways of trauma-informed care. Earlier, someone in the chat said that they already are screening for depression, and that is great. We're going to dive into some more screeners that may be new to you, maybe new to some, maybe old to some. So trauma and screening is very important because we need to know what we're being faced with in the clinic so we can better treat those things and better address those things. Creating a safe and welcoming environment is something that is up to everyone in the clinic, no matter where you work, no matter if you're client facing or not, no matter if you're clinical or non-clinical, right? That's why trauma-informed care, I do believe that's why that this workshop was placed in the both categories. So it's not either or, it's everyone. Building trust with clients and patients, again, a charge that is up to everyone. Empowering patients in their care decisions. We talked about that in the last slide, giving them voice, choice, and positions within the organization when appropriate and when necessary. So now we're going to hop into some screeners. The first screener is the Patient Health Questionnaire. This is a screener that screens for depression. And I have this here. I do realize, again, we are a mix of non-clinical and clinical, but just looking at some of these questions, we know that these questions aren't necessarily hard to ask. They are written in plain language, something that we speak to our clients in plain language. We don't go in with super medical jargon or super, mental health or behavioral health jargon. It's really simple and plain. Over the last 2 weeks, have you had little interest or pleasure doing things? Feeling down or depressed or hopeless, right? These are written in plain language. And again, this is a screener that can be used and implemented into your AHR system. They also, the PHQ-9 can actually be completed by the client. They can self-elect to do this on paper. I see someone in the chat say some of our practices have these on paper. Yes, exactly what I was saying. So yes, Jinx. So that, it takes the pressure off maybe the medical assistant or the nurse, and we can still get through that provider time ticker that's constantly clicking. You know, we only have 15 minutes here, 10 minutes here. Oh, the patient went to the bathroom. We have to log that in the chart. I'm aware of those things as well. But these screeners are definitely something that can help us assess who we are serving and how to create a trauma-informed environment for them. This is just one screener. I have two more. This screener is the Adverse Childhood Experience Screener, and this goes directly back to the slide when we were talking about 64% of adults have experienced at least one traumatic event before the age of 18. This is how that data is collected. Again, plain language. Do you feel that you didn't have enough to eat, had to wear dirty clothes, or had no one to protect or take care of you before the age of 18, right? These questions are very straight to the point. This one is a little bit more in depth of assessing for trauma. So some of the questions are not as light as the PHQ-9 or the PHQ-2. I see that in the chat. The PHQ-2 is an abridged version of the PHQ-9 that has 2 questions instead of 9 that can assess if a person is in need of extra support when it comes to mental health. When should this be used? Okay. The PHQ-9 can be used at every visit because it's monitoring the last 2 weeks, right? The Adverse Childhood Experience Screener can be used once across that patient's time in your clinic because that data is not going to change because it's up to the age of 18. So this is something that I think is very good to be collected at intake. Again, PHQ-9 is over the last 2 weeks. So I would recommend that that be collected every time that client walks into the office. Great question, Taylor. And then the primary care, which is developed strictly for primary care, post-traumatic stress disorder screening. As I said before, the PTSD and one traumatic event does not equal the same thing. So we never want to use this screener unless we already know that a traumatic event has taken place. This is not a screener that should be given to everyone. This is only if a traumatic event has been taking place. And then we're assessing the severity of that traumatic experience because again, because of those protective factors that we have and our clients have, it may never develop into PTSD. And again, these questions are in plain language, no medical jargon, no mental health theory is being asked in these questions. Is saying in the past month, have you had nightmares about the events or events that you did not want, that you didn't want to? Did you try hard to think about these events? Try hard not to think about these events or went out of your way to avoid situations that made you think of these events? And when you look at these questions, these are really asking, are your daily tasks being altered? Can you continue to do the things that you have planned to do without a mental challenge? And if you do have a mental challenge, how severe is that mental challenge? Okay, those are the end of the screeners. Please feel free to ask me questions. Yes, the GAS-7. GAS-7 is a screener for anxiety as well, and it monitored the last 2 weeks. And so it's one of those that you would do each time someone is in the clinic. Thank you, Heather. And so now we're going to spend the next few minutes before Q&A going back into how we can use everything that we talked about today, even before my session. Especially in this session, we can scroll back up and see the chat. We can also, go back a few slides and look at those screeners, look at the 6 guiding principles from SAMHSA and CDC. But what can we do with all the information to ensure that we're actually applying it to good use, right? How are we starting good trouble and making trauma-informed decisions so that we can increase our patient pools, make people come into care who wouldn't previously choose our health centers because they may have not felt safe? And that is continuing staff and training and education. That's just like we're here doing this morning. So check box, we just need to continue to do that because like I said before, trauma-informed care is not a one-size-fits-all. And honestly, what worked in trauma-informed care in your clinic in 2017 to 2019 may not work now because we have endured multiple epidemics and a global pandemic. So sometimes we need to shake things up and go back and collect more data to see if things have changed, right? So it's a constant a constant evaluative process and evaluating quality and different benchmarks in order to achieve optimal trauma-informed care. And then we need to explore trauma stewardship and preventing trauma re-traumatization. And so that is on us as a workforce, right? And I do have some theories on how to get around that, but how do we steward the trauma that we may experience working in a health center, right? Because if we know, again, if most adults have experienced at least one traumatic event, then we're working with some traumatic events under our belts, right? And we're also serving people who may have more than one. So how do we take care of ourselves as we prepare to do the work so that we sustain ourselves, so that we can continue the work, because healthcare is so important. Another thing we talked about, well, we will talk about, is EMR and EHR integration. And it's great to hear that some of you have already have those systems in place to screen. And whether they be on paper or already in the EMR, those things are ways that we can not only assess for trauma one time or multiple times, they're also living in the chart. So we're able to see those things before we see a client. We're able to create some buffers when we see a client. We may want to talk with that client a little more before we dive into that chief complaint, that why are you here, right? It gives us some preference, and we understand who we're speaking to, as we have already built the entire health system. So they feel welcome when they walk in the door. They feel welcome when they are in the parking lot, because there's enough spots for them to park and feel safe. There's enough accessibility spots for those who may need it, right? So that's how that looks. And then developing partnerships that create whole person care. I know a lot of you are already in patient-centered medical home frameworks, or the federally qualified health center approach. But for those of you who aren't, how can you work on developing partnerships that create the whole person care? Even if you haven't received FQHC status or FQHC lookalike status, how can you begin to create those things in a way that works for your health center? And I see something in the chat. Medical trauma is definitely important to remember in that way too. Absolutely, absolutely. Medical trauma is a part of trauma-informed care, because some people have had negative challenges and negative indicators when it comes to medical treatment. So we want to be mindful of that as well. And I do want to leave time for Q&A, but I do have 3 books that have fortified my trauma-informed care journey. And they have helped me as a professional and as personally in my personal life with my family. And that is My Grandmother's Hands, which is a book talking about racialized trauma and how to heal from that. And it also talks about, from a very social work perspective, but a mental health perspective, how to show up in the work as well as healing yourself at the same time. The Body Keeps the Score is an amazing book that I suggest to anyone, anywhere, which really shows that if we don't take care of our own trauma within the mind, the body, or soul, just that we talked about earlier, that physical, that mental, that behavioral signs of trauma, that it kind of stays there. And sometimes it's the headache on days when we may not feel great, or on anniversaries that may not feel great. Sometimes it's the backache. Sometimes it's insomnia on certain times, or throughout certain times of the year, or in the break of a natural disaster. Some of those things really show up in our bodies. So it teaches you how to listen to your body, and then how to heal through that, not only physically, but mentally and behaviorally as well. And the third book is Trauma Stewardship, which I recommend to anyone working in a helping or healing profession. It teaches you how to practice self-care for your communities, your clinics, within your peer supports. It teaches you how to navigate those relationships so that you can sustain yourself in the work, and you're continually and constantly learning about yourself as well as the populations that you serve. Again, just the suggestions. I'm not, like I said before, I don't have any disclosures to make, so I don't have any connections to any of these authors, but they're all great. I see something in the chat. Which would you recommend for a mother who has children that have went through trauma? I'm also a foster mother, and I tend to have to step back to try to understand everything that's going on. First, thank you, Sabrina, for feeling comfortable in this space to request support and also to be willing to read books outside of your work and things like that. So thank you. And it sounds like you're already very resilient because you are asking for help. I would say that The Body Keeps the Score would probably be the one that I would suggest as the first book for someone in this situation. It's a pretty thick read, but it goes under it really talks about how the body keeps the score within adults and how it goes throughout the lifespan. And so that's why I suggest that book first for someone in this situation. So thank you, thank you. And now we're just heading on into the Q&A. Again, my name is Megan Dunham. This is my email. Oh yes, I have questions in the chat. Okay, thank you so much. I'll get to these as quickly as I can because I know we're almost at time. The first question is, you mentioned current practice may not work with the next couple of years, and what worked a few years ago may not work now. How can healthcare providers stay updated on best practices for trauma-informed care? That is a wonderful question. I'm actually going to go back to the 6 principles. Oops, sorry. I'm going to leave it alone, actually. Oops, how can I go back? Okay. Thank you so much, team. So the 6 principles and guides to implementing trauma-informed care are not going to change, right? What is going to change, what may change in the matter of years is what happens environmentally, what happens politically, and how your patient pool and your patient panel changes. So the most important thing that we can't control of the 3 things that I just named is patients, right? So hearing what works with patients, allowing them to do patient feedback surveys, getting them involved, having them sit on your quality teams, having them sit on your boards, and then helping them to understand both what you all do as a care center, but also their role in active participants in the care that they receive. So I think that is the best way to stay updated, is to be informed by the people that you are serving. Hopefully that is helpful. And the next question is, what are some subtle signs of trauma that healthcare providers may overlook? Yes, I think this is a really good question as someone who previously worked at a FQHC. Sometimes signs of trauma looks like someone who chronically has no-shows. And I know that can be very frustrating to our productivity teams. It can be very frustrating for our clinical teams, but that is a very common sign of trauma. That may mean that someone may need to go see the behavioral health team or the mental health team before they get into primary care. And I know that there's some systems that prevent that because of the bottlenecks that may take place, but sometimes that may be what that client needs. And we need to figure out what is preventing them from coming into the clinic. Other things that may look like different signs is irritability and not understanding how to navigate the healthcare system. Again, we learned about this earlier. Some people may be receiving information from their doctor, from their pharmacist, but they don't truly understand what those things mean. And so having someone who is a peer or someone who can speak in language that is not medicalized to speak with them may be the remedy for that. I hope that is helpful as well. And the next question is, how can healthcare providers differentiate between symptoms of trauma and symptoms of other conditions? The best way is screening and talking to clients, and that also requires a multidisciplinary team. And so that may require doctors and physicians and MAs and NPs to talk to the social work team as well. That may require the social work team and the other providers to talk to the diabetes team. It may require them to talk to women's health teams. It may require them to talk to those who lead I'm escaping on the name right now, but basically healthy food and planning and diabetes prevention work, all of that the prevention teams that go out into the neighborhoods, all of those people need to speak in order to be able to differentiate those things. Another great point is screening. And screening along with testing and lab testing. So if someone, you need, just like you have a differential diagnosis, you have those in mental health as well. So combining both of those things, ordering lab reports for something that may look like a person is depressed, it may be low iron, and that may be like that iron deficiency may be leading into a more chronic condition. So all of those systems working together is truly how we get to that point. And that requires a system to be in place before we can even get to that point. So creating a system in which interdisciplinary providers are working together is definitely something, is a start to answer your questions on how to differentiate. And I see something, yes, low B12 levels are common. Yes, absolutely, absolutely. Low B12, low vitamin D is another one. And these are things that can be remedied by just a regular vitamin, right? But sometimes they require even more. Okay, and I have another question. How can healthcare providers practice active listening and validating effectively in a busy clinic setting? Absolutely. Again, I know that the timer is always going. We have 15 minutes here, 2 minutes here, all those things. I understand that. So thank you for your question. I think active listening in that space is allowing clients to lead the conversation. So we know that we have to collect certain data points when we're meeting with clients. We know that we need to meet with them about their chief complaint. We also need to get vitals. We also need to at least say hello, right? We have to do all of that. And earlier this morning, we learned about, just making eye contact with clients, not being focused on other things in a busy clinic setting, but also allowing the client to guide the conversation. So maybe we introduce ourselves if they don't know us, we say hello, and then we ask them how they're doing and if there's anything that they would like to discuss, right? So we're active listening because we put the onus on the client to speak. And if we have questions, and that may open the avenue for referral. So I think active listening can be a simple or challenging thing depending on the clinic in which you work, but it also revolves around the client and giving the client space to speak and also time to speak, because we know, as I guess many of us are pros at what we do. I'm going to say that. I'm just going to go ahead and call you all pros, definitely professionals, because of everything that we talked about in the chat, all the answers. So I'm confident that you all are able to get what you need in order to complete what is ever in the chart, while also allowing the client to speak. Hopefully that's helpful as well. Do we have any more questions? I think I have a few more minutes for Q&A. Okay. Well, again, my name is Megan Dunham. Very honored to be here in this setting. Of course, I have shared before how important trauma-informed care is to my work. Please reach out to me if you have any questions about these books. I know you'll have the slides, but please reach out to me. I will email back. And just again, thank you for allowing me to be here. I know this was a tough last session because you all have been here since 8:30. So thank you for toughing it out with me and also being super interactive. And I wish you all the best and a great weekend. Thank you so much.
Wonderful. Thank you so much, Megan, for such an informative and helpful session. We're getting a lot of that feedback in the chat here, so we'll just echo what folks are saying. Thank you so much.